Well, I have one for the transplant presentation. First of all, I thought all three were great. You're clearly using all of the advanced biocomposition measures, so that was nice to see. In the transplant community, you use steroids with the pancreatic enzymes. Are steroids used in all settings, like Megase? Even with GVHD, when steroids are used to treat GVHD? And then what is the reasoning for pancreatic enzymes?
Thank you for your question. Let me answer in such way. The first line therapy for graft versus host disease is glucocorticosteroids. If they are ineffective, we use another drugs such as rituximab and photopheresis and other procedures. As to say about the usage of glucocorticosteroids as appetite stimulants, we don't use it, and use migastrol acetate alone. And the second part of your question about the pancreatic enzymes, then we see laboratory data about the pancreatic insufficiency. We use low dose of pancreatic enzymes.
Okay. Right, thank you.
I just had a comment on the appetite stimulant study which you did. The randomized trial from Children's Oncology Group done on migastrol acetate, although it's not a huge randomized trial, it also prospectively looked at using adrenal functions as well as the body composition of the participants who receive migastrol acetate. While it did improve weight, but what it turned out in body composition was it's mostly fat and water. And second, a significant number who got longer migastrol acetate, they had developed adrenal cortical dysfunction. So I think those are two concerns one must remember, although the data was quite promising and interesting to note that those are the two possibilities which happen, and then if you're just gaining water and fat, the true benefit of appetite stimulants is really questionable.
Excuse me, can you repeat the question because I can't hear from...
Okay, do you want me to repeat that? Should I repeat? It was just a comment on the use of appetite stimulants. Other thing which I have a comment, although what we showed in many studies from the low-income countries and middle-income countries was that there is a high prevalence of malnutrition, but even from Russia, when I saw your prevalence, it's quite high. If you use mid-arm circumference, is in some categories reaching 40 to 45%, which is, I think, a very high prevalence of undernutrition in your setting as well. So it does require, I think, and our entire group of hospitals in Russia, a very systematic approach to intervention early, because if it's remediated early, then the outcomes will be optimized. Do we have any other question from the audience?
Can I have one question to Elena Ladas, maybe? What's your opinion? Is the optimum timing to place percutaneous gastrostomy prior to allogeneic hematopoietic stem cell transplantation?
I'm sorry, could you repeat it?
What's the optimum time to place the gastrostomy prior to allogeneic stem cell transplantation?
Gastrostomy So no, we don't at our center. I can only speak about our center. I think I don't know if maybe Dr. Rogers wants to comment on that. We will use nasogastric tubes, but not gastrostomy tubes. But Dr. Rogers, I don't know if you have a different experience.
The policy in our transplant unit is to place a tube, either gastrostomy, but usually a nasogastrostomy tube on day 0 decision for that was it's usually after the vomiting of the conditioning regimen and it's prior to the onset of mucositis. We did a retrospective audit about this, and we decreased by that policy, we decreased the use of supplementary parenteral nutrition by over 50%. So most of our transplantation patients have NG tubes down for until count recovery, until they're normally eating, and we avoid the use of parenteral nutrition.
That's interesting.
Yes, our colleague from Bangladesh, please.
Yeah.
Yes, go ahead.
Thank you very much for recognizing. Yes, I'm Dr. Anwarul Kodim from Bangladesh. I'm working in a lower middle income group country in a specialist center dealing with the pediatric oncology patients for long since 85 things. My question to probably to Dr. Rajesh. Using about this MNT for the nutritional support, and I just want to know how you just make these nutrients free of bacteria or this sterilization of this product. And second one is how do you adopt the nutritional support for the patients who are developing diarrhea as well as mucositis? Thank you.
So I think that's a very important question which we also had when we started using it. So if we look at the composition of MNT or RUTF, it's basically 4 groups of constituents. One is usually it's got one cereal, and in this case what we use is peanut butter, which is commonly used. Second component is usually milk solids. Third is usually sugar, of course, and it's got micronutrients added in the adequate amount, and vegetable oil. So the water content of the last constituted mixture is less than 1%. So since the water content is low, even if you kept it at room temperature for months together, up to 3-4 months, nothing happens. It does not get contaminated, unlike the other nutrition supplements. And that's the biggest advantage of using it in LMIC, that you don't really need to worry about contamination. Of course, while preparing it, if you're using peanuts to prepare it, you need to be very careful because peanuts get aflatoxin very quickly. So we need to be very sure, and we have fluorescent methods available to screen peanuts before we make it. So that's the only precaution which requires pre-constitution. Post-constitution, it's very safe and stable. A second question you asked was, what do we use in patients with mucositis or diarrhea? In most places in India, we do have access to elemental and semi-elemental supplements, and we use them preferably in those patients. But where there is that's not available, you could make a homemade some partly elemental by using some enzymes, and we use that also in our setting. So those are both options we exercise.
Okay, thank you very much.
Well, I have a question as well.
Yes, please.
Yes. I am Dr. Chaudhry Yaqub Jamal. I am a professor of pediatric hematology and oncology in Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh. I have a question to Dr. Bijesh. Well, you were mentioning about the ready-to-use therapeutic formula. What I know recently in Bangladesh and even in India, nationally for patients, without cancers, nationally, these are not being encouraged that much. And nationally, there has been given information to the WHO as well, because in Bangladesh, a project with ICDDR, International Center for Diarrheal Disease Research Bangladesh, really was intervened by Bangladesh Pediatric Association and other NGOs as such, that ready-to-use therapeutic formula should be taken, in a different way, not nationally in a process where, in the community, in other places, it should not be encouraged. So there was an Indian authority, I forgot his name as well. It was really discouraged in that perspective. So what is your comment regarding this in oncological perspective?
Okay, I think that's a very, very relevant question you asked because we face the same challenges in India, as you said. So there is the perspective while using RUTF with community malnutrition is totally different. The reason is community malnutrition in most low and middle income countries is highly prevalent. And currently RUTF, which I showed, there are many commercial options while using RUTF. They are pretty expensive. So if you use it nationally in a community malnutrition which is very prevalent, the cost incurred for treating malnutrition is going to be huge at a national level. And while these have been shown to be more effective than the conventional home-based interventions, but these are not considered cost-effective interventions at a community malnutrition level. However, when it comes to oncology, which is a very small subset, and these children require more intense nutritional support, that number is very small, and that cost effectiveness changes completely because the benefit is far more and the cost incurred is very small. So that's where the equation changes, and that's how we are able to access it for this group of patients. And if you're able to constitute it yourself instead of depending on the providers in your center, then the cost of production comes down drastically, and then it becomes even more cost effective.
Thank you.